Bioptics in treatment and management of hyperopic astigmatism.
Thank you very much. This is actually a multifocal IOL and not a phakic IOL, but it was put in this session. I don't know why. I'm a consultant to AMO and as such have to acknowledge a financial interest. When we deal with phakic IOLs or multifocal IOLs, the general goal is spectacle independence. I think we all agree about this. When we now look at patients with hyperopic astigmatism and consider the spherical nature of a Technis multifocal IOL, we have to remember that this Technis IOL cannot correct the astigmatism. So we do need to perform a touch-up procedure, and LASIK can be performed only about 3 months afterwards because of wound stability. I wouldn't like to do this just immediately after the IOL implantation. So the question now was, how do we achieve spectacle independence maybe a little earlier? And our idea was to actually offer a refractive package. The multifocal IOL is offered as a package with intralace LASIK, and the intralace flap is actually created prior to the IOL surgery without lifting it if the astigmatism was preoperatively 2 diopters or more. Then a custom view LASIK enhancement was performed about 3 to 4 weeks after the IOL implantation. In this case, wound stability is no issue because the cut was being performed before the IOL implantation. So part 1 of the surgery actually consisted of the intralace laser flap creation at the day of the IOL surgery. The second part then, immediately after the flap creation, was to implant the multifocal IOL. This is not made any more difficult because the flap was not lifted, and that's the big difference as compared to a microkeratome cut. We used the Technis aspheric multifocal IOL. It has a prolate anterior surface and a diffractive backside. Because it compensates the induced spherical aberration of the cornea, provides excellent distance and near visual acuity. And we also use it in some patients as a mix and match procedure if patients require good intermediate vision as well. But this here is just on bilateral implants. How do we achieve perfect results? Well, in multifocals, we have to be very careful that the posterior capsule is really clear. So if there is any faint opacity, we have to perform YAG capsulotomy. And obviously, patients have to be ametropic. We have to correct residual ametropia using laser vision correction. That takes us to the third part of this procedure, the customized laser surgery. We use the Vizec Star S4 for this surgery. The question has been asked many times, why do you need customized? Well, the customized LASIK provides the perfect match of the measured and the treated area. And remember, we are dealing with patients with high astigmatism. So when we customize the treatment, we are guaranteed that the treatment is on axis. This will give us better results of the astigmatism correction. So higher order aberrations are not that much of an issue actually, but the astigmatism is treated more precisely. Let's look at the case example, 62-year-old patient, a typical patient, plus 3.5, minus 2.5 astigmatism. We did the flap with the intralace and the Technis multifocal, and as expected, there was residual astigmatism, so a wavefront guided treatment was performed, which actually corrected this. And when we now look at the map over here, we do see that we also had a significant reduction of coma, pre-op, to post-op, and of trefoil, pre-op to post-op in these patients. Obviously, both maps are the same scale. So yes, wavefront guided ablation seems to work. And in addition, you also see that the point spread function is better in these patients. We have results of 14 eyes of 8 patients, all Technis multifocal IOL, and the custom view LASIK with the Vizec laser was performed 3 to 4 weeks afterwards, as I just said. Let's look at refraction first. Sphere and cylinder, as expected, were significantly reduced by the LASIK procedure. That's obvious. That's why we do this. When we also look at the amount of higher order aberrations, interesting finding is that we were also able to actually reduce the higher order aberrations. That's 0.43 microns before the customized laser vision correction and 0.29 microns afterwards. So on average, we are able to reduce the higher order aberrations through the customized laser procedure. In summary, based on these results, I would say that multifocal IOLs can be combined with intralace flap creation and a wavefront guided ablation to achieve perfect vision. One of the limitations I didn't mention here, a customized ablation is only possible with diffractive multifocal IOLs, such as the Technis multifocal or the Restore from Alcon. It is not possible with a refractive multifocal IOL, such as the Resume, because the wavefront sensor cannot measure the IOL optic well enough. The intralayer flap creation prior to the IOL surgery allows us for earlier laser vision correction. We don't have to wait for 3 months for the complete visual rehabilitation of our patients. Thank you very much.
Very interesting. Please, I have a question. When did you perform the preoperative wavefront measurements? I guess that was after the IOL implantation?
Yes, the wavefront measurements were obviously after the IOL implantation. We usually do them on the day of the enhancement surgery. So typically the patient has the IOL implant, patient is scheduled for the enhancement 3 to 4 weeks later, and on the day of the enhancement we first do the measurement with the wavefront sensor and then we do the enhancement.
Because with multifocal IOLs, even autorefractor measurements can be difficult to perform. Is wavefront measurements...
It's possible. The interesting thing, we really looked at this. We really looked at this in an experimental eye also. And as I mentioned, you can get reliable wavefront captures with a Hartmann check sensor like the Vuzix WaveScan in diffractive multifocal IOLs. You cannot get reliable measurements in refractive multifocal IOLs because the image is simply too much distorted. But with a diffractive multifocal IOL, you actually get all these spots the wavefront sensor creates doubled. And the second one is fainter, so the software doesn't mix up the two spots. It's very interesting, but it really works in about 90% of the patients, and you really see that you have a reliable wavefront measurement.
Thank you. Please, microphone number 2.
I have the same question that already was answered. I was thinking that Hartmann shock is not a good device to measure wavefront after multifocal IOLs. Yesterday there was a talk that they had another device, a better device, more precise device for measuring wavefront after multifocal IOLs. So in practice you have good results, but I don't know if theoretically it works, you know.
Yes, we have the results. We actually went to Vuzix, and Vuzix did an artificial eye chamber, and they put in the different multifocal IOLs, and we measured them with the WaveScan Hartmann check wavefront sensor. And we evaluated all the images taken and then the maps calculated, and it turns out that you have both reliable refraction and reliable and reproducible higher order aberrations with the Vuzix wavefront sensor. So yes, for this experimental setup it works. And then we went to the clinical results, and I treated patients as I just showed, and we also got reliable results with a significant reduction. On the other hand, with the Resume, we have one clinical case, and this is not really working at all. The refraction was something like 2 diopters off. So the wavefront sensor really doesn't work in a refractive multifocal.
So the customized ablation will not affect the multifocality of the lens after the operation?
That's absolutely correct. It did not affect the multifocality of the IOL because with the Technis, the two foci are very much apart. We have one at distance and then one more than 3 diopters apart. So this is not confused. It just corrects the one at distance.
Okay, thank you.
Thank you very much. And now Dr. Marino, toric artiflex.